Hello, thank you for joining. We'll begin in a moment. Just want to give everyone a chance to jump on. Thank you for joining. Begin in a few moments. Okay, let's get started. Hello, everyone. Thank you for joining us for tonight's webinar as we share cardiomyopathy Q&A. My name is Nikki Butler, and I'm the Director of Digital and Social Media for the Dilated Cardiomyopathy Foundation and the Genetic Cardiomyopathy Awareness Consortium. We're so glad you can be with us. During our 2025 series of webinars, we've received more questions than allotted time for live answers. So for tonight's webinar, we've gathered a panel of experts to address your questions concerning cardiomyopathy, genetic therapies, clinical trials, and genetic testing. Next slide. Actually, we'll advance one more. I do have a few housekeeping items. All attendee microphones are on mute upon joining so that you can hear our experts. And thank you to those who submitted questions ahead of time. If you didn't get a chance to do so, you can enter your questions into the Q&A feature of Zoom. And we do hope to get to many of those tonight. We'll see. We may need yet another follow-up. Thank you, Justine, for your technical assistance with Zoom behind the scenes. And then let's advance once more. We do have a poll for tonight. So let's push that poll forward. Who is attending tonight? Are you best described as a cardiomyopathy patient, a family member or friend, a medical professional, or an industry professional? A second and answer that poll. That. So primarily cardiomyopathy patients and some family members. We do have a few professionals as well. Thank you. And let's keep rolling. I do want you to know that this webinar is being recorded and it will be posted on our YouTube channel following tonight's discussion. As registrants, you will receive an email with a link to the recording. Our YouTube channel also houses a library of our previous webinar recordings. And using the auto translate feature, these videos are available in 54 different languages. Next slide, please. I want to give you just a little bit of background. The DCM Foundation, focused on dilated cardiomyopathy, created the Genetic Cardiomyopathy Awareness Consortium, or GCAC, in 2023. This effort began in 2022 when the DCM Foundation recognized a major gap. Genetics in cardiomyopathy wasn't being widely discussed, not by medical professionals and certainly not by patients. And we realized something important. You can't talk about genetic cardiomyopathy in silos. Many gene mutations cross diagnostic boundaries. For example, a single gene variant might cause dilated cardiomyopathy in one person and arrhythmogenic cardiomyopathy in another. Because of that overlap, we needed a broader, more inclusive approach. So GCAC was formed to raise awareness and provide education about genetics and cardiomyopathy across all types. And next slide. In just the past 2 years, we've made meaningful progress. Awareness of genetics and cardiomyopathy has increased significantly, both in the medical community and among patients. When we launched GCAC, we started with 8 patient groups. Today, we've grown to 11, and we're continuing to expand. This momentum shows there's a real need and a real interest in understanding the genetic side of cardiomyopathy. Next slide. We do want to highlight these 11 patient groups that are participating in the Genetic Cardiomyopathy Awareness Consortium. We certainly want to thank each group for participating. It's great to have a coalition of 11 different groups working together to solve a real problem with patients. And next slide. We are honored to be joined by leading experts who bring deep clinical research and patient-focused perspectives for tonight's discussion. Firstly, we're pleased to welcome Dr. Neil Lakdawala, Assistant Professor of Medicine at Harvard Medical School and a cardiovascular genetics specialist at Brigham and Women's Hospital in Boston. Dr. Lakdawala is internationally recognized for his research on the genetic causes of cardiomyopathies, the natural history of these conditions, and clinical trials in this rapidly evolving space. His clinical expertise includes hypertrophic and arrhythmogenic cardiomyopathies, cardiac sarcoidosis, congestive heart failure, and heart transplantation. We are also joined by Dr. Kathy Crispell, President of the DCM Foundation Board. Dr. Crispell is a cardiovascular disease and advanced heart failure transplant specialist with decades of experience at the Portland VA Medical Center, Oregon Health and Science University, and Kaiser Permanente Northwest, where she served as Chief of Cardiology and Chief Medical Officer. She established advanced heart failure and cardiac mechanical assist programs, and today continues to care for patients while also contributing to global health efforts and guiding the DCM Foundation. Unfortunately, due to a conflict, Megan Sutton is unable to join us as a presenter tonight. However, we are in excellent company with Dr. Lakdawala and Dr. Crispell. Please join me in welcoming our experts. We are grateful to have your expertise with us. And now I'll turn this over to our Executive Director, Greg Roof, to moderate the Q&A.
Thank you, Nikki. And thanks so much for Kathy and Neil helping us this evening. Again, one of the reasons we wanted to have tonight's webinar is we've had a lot of great webinars this year. We've been overwhelmed with questions, and we thought it would be really interesting just to have a webinar to catch up on your questions. And we're now overwhelmed again with questions. So we're going to run through, I think we had about 30 questions submitted prior to the webinar, and we're going to run through and try to get through those questions tonight. And if we can't, and you're happy to submit questions also, and we'll try to answer them by the end of the webinar. If not, after the webinar, we can send the questions out in email. So again, thanks all for attending and Justine behind the scenes. So I'm going to start off first, and I'm going to roll this to you, Kathy, and if Neil, you want to follow up. The first question really is on BAG3, and a question from Ketazarnia had a question about, is talking about BAG3 as potentially a neuromuscular and a restrictive cardiomyopathy. Most of the information we've presented to date is on BAG3 as a dilated cardiomyopathy gene. And so she asked a question about that. And then also, is there hope for folks with BAG3, not only DCM, but restrictive and neuromuscular? Kathy, you want to take a shot at that?
Yeah, I think BAG3 is a complex variant. It's probably it's more than one variant within the gene for BAG3, and there can be different kinds of phenotypes. And I'll let Dr. Lakdawala go over that a little bit more in detail. But I think going back to the question about is there hope, even though we've kind of this organization has really provided a lot of focus on the dilated phenotype of BAG3 variants. I think there is hope for attention being brought to the other types of phenotypes that can be associated with BAG3 variants. And that's one of the reasons why we hold these webinars and why we encourage people to participate in clinical trials and in research so that we can increase our understanding of these very complex genetic diseases. So yes, I do believe you can have hope that we will address the other forms of and phenotypes of BAG3.
Thanks, Dr. Criswell. And I just want to acknowledge this is a very sophisticated question that came from a leading researcher in the field. So the question was posed by someone who's contributed substantially to our understanding of this disease. And as I think about BAG3 related heart disease, there is the loss of function type that is associated with dilated cardiomyopathy, where patients have a gene variant that we think leads to the body making half the amount of necessary BAG3 protein, as opposed to what we know about BAG3 related restrictive cardiomyopathy, where the missense or a single misspelling in that gene, if you will, protein is probably a driver of disease pathogenesis. And I think your point, Dr. Criswell, is right, that these have different effects. And while we may not be able to use the strategy of gene replacement therapy, which is what will happen in early stage gene therapy trials for people with missense related BAG3, I think what we learned from that, what we learned from some of the tissue studies in those patients, but then also from comparable studies will be helpful. But I totally get how that group of patients is frustrated, because if you have restrictive cardiomyopathy, you probably had a much longer path to a diagnosis than many patients with hypertrophic or dilated cardiomyopathy. It's a tricky diagnosis to make, and I know Dr. Criswell remembers this. It's like poor cardiology. Don't miss restrictive cardiomyopathy. It's a hard one as a clinician to make, and so for the poor patients who struggle with a delayed diagnosis, only to get to the point of knowing what they have and not necessarily seeing an obvious therapeutic immediate option can be frustrating, but I'm hopeful too.
Great, thank you. Thank you both very much. And there's another BAG3 related question from Laura. Thank you, Laura, about somebody has a gene variant, BAG3, for example, in her family, and they, the genetic counselor talked to her about people getting sick in a second hit. So, and whoever wants to start, so what is this? What is a second hit, and how does that affect people with potential genetic cardiomyopathy?
Go ahead, Neil.
Yeah, it's a second hit is language we actually initially used in cancer, that it took multiple insults to somebody's genetic or a cellular genetic code to culminate in cancer. But we learned not so long ago that for some people with a genetic predisposition to cardiomyopathy, certain environmental exposures could contribute to the development of disease. And so it's best understood, we think, for Titin-related cardiomyopathy on the dilated side, and then PKP2-related ARVC. In the case of the latter, it seems that high-volume endurance training makes people who have PKP2 variants more likely to develop the disease and perhaps lead to more rapid progression. In Titin-related cardiomyopathy, we're still really working it out, but it does appear that there may be an effect of heavy alcohol use, of certain types of chemotherapy, and then in a small subset of women, pregnancy-related hemodynamic stress. So there's a signal there, but there are so many questions to be answered, and I don't think that we could necessarily apply the lessons learned in one genetic disease to others. So for instance, the exercise risk in PKP2 ARVC may not be the same for someone with BAG3 or with Titin-related cardiomyopathy. And I think ongoing research should help answer that question. I know our group is quite interested in addressing this, and I know others are too. So I'm hopeful that this patient will have a little more guidance based on data in the not so distant future. I guess the only thing that I almost comprehensively recommend my patients who are at genetic risk or have mild genetic cardiomyopathy is to avoid heavy daily alcohol use, because that in and of itself can be a cause of cardiomyopathy.
Great, thank you, thank you. Next question is from Sabine, and Neil, this will be for you. And Sabine has been diagnosed exercise-induced ARVC, gene elusive, and knowing that there are a number of specific gene therapy clinical trials for cardiomyopathy going on around the world, what does that mean for somebody that's gene elusive? So what happens with people? We know they have genetic cardiomyopathy. We don't know the exact gene that's causing it. How are they going to get helped in these gene therapies that are mainly gene specific?
It's a tough question. I mean, I think that in the short term, I don't think that gene replacement therapy makes sense for a patient who has cardiomyopathy, but it doesn't miss or isn't lacking that gene. So the next stage of this, I think, is sorting out the complex genetic drivers of disease. So we, in this world, think a lot about I do or I do not have the variant that causes cardiomyopathy in my family. But there are other genetic contributors to disease that can sometimes be captured as something called a polygenic risk. It sort of incorporates everything in your genome into how that influences your health. And so studies in patients like Sabine who have gene elusive ARVC may help us identify new pathways and then potentially help her maybe have new therapeutic approaches. I don't think, though, that the current version of gene therapy will be a part of that. What might be a part of that in the not so distant future could be small molecules. We think of small molecules, and in this world, think about drugs like mavacamten in hypertrophic cardiomyopathy that seem to be effective in people who do and do not have a genetic cause for their hypertrophic cardiomyopathy.
Oh, great, thank you. And kind of from Roberto, at what stage is the research regarding a possible genetic cure? Complex, very short question, but very complex. Neil, what do you think about that?
Yeah, I mean, like, such a great and important question. I think defining a cure in a patient who already has established disease with gene therapy as we currently understand it doesn't seem to be highly likely. So if you have severe cardiomyopathy and you receive gene therapy and it works, the current expectation is it's going to prevent the disease from getting worse and maybe lead to small or moderate improvement, but not complete resolution of the disease. In terms of maybe using it as preventative therapy, theoretically that could prevent someone from ever developing it, but I don't think we're close to administering gene therapy as a preventative therapy. There are a lot of stages of safety that would need to be crossed. So that said, I think short of a cure, an improvement in cardiac function could be really meaningful in terms of living longer, living better, including better quality of life and better exercise capacity. So I think there's still a lot of improvement to be had short of a cure.
Okay, thank you. Thank you very much. Kathy, 20-year-old DSP patient diagnosed 2.5 years ago, has had a bit VTAC episodes, cardioversions, ablation, and an AICD, being treated with, I think, optimal, probably therapies, medicine therapies, and again, family history. There, some families have it, some families not. Do we think that this candidate, hard question, would be a potential candidate for gene therapy? And is there gene therapy that could strengthen and repair heart tissue? I think Neil answered the second part of that question, which is most likely making it a lot better is probably not the cure. So Kathy, what do you think about the patient, this patient being a candidate for gene therapy?
Well, right now, there aren't any FDA-approved gene therapies for any type of genetic cardiomyopathy. There are, to my knowledge, two clinical trials for genetic cardiomyopathies, one for HCM and the other for Danon disease. But outside of that, right now, there's not, a clinical trial specific for DSP. But that doesn't mean that there might not be in the future. And so, I will just leave it at that and say that it's not available now, but it could be available in the future.
Great, thank you. Kathy, another question from Margaret. Does walking or exercising with chest pain damage your heart? Second part of the question is, how likely is it to have gene testing done twice when the first one was elusive?
Yeah, well, let me take the last question first. Yeah, if your genetic test, if you have a cardiomyopathy and and it's in that idiopathic category, meaning we don't really know what the cause is, and you've already had one genetic test and it didn't really show any genes that we know are implicated in the process of cardiomyopathy. And it's been, at least a few years since you had that test, and it's probably worthwhile getting retested again, because we're always discovering and identifying more information and more genetic variants that could, maybe they weren't identified at the time that you had your genetic testing done. So that's not unreasonable at all. And so as far as the chest pain and walking, that's a complicated question, because it all depends upon what kind of heart disease you have. Sometimes people can have a couple of different kinds or more than two types of heart diseases. And maybe one is causing a chest pain for a very specific reason, and another one is not. So really, it's really to clearly answer the question, which I won't be able to do today, is I would need to really understand really what is your heart problem or problems. And that would, and knowing that, would be related to whether or not that could be harmful to you. So like if you have coronary artery disease, in addition to having a cardiomyopathy that may be genetic in origin, then, exercising and developing chest pain when you exercise could be very significant. And so I would recommend for this individual to ask that same question to their physician who is taking care of them and has all of that information available to them. And they're going to get the best answer from their healthcare provider.
Great. Thank you very much. Next one for Neil, because I think you know a bit about FLNC variant. So the question from Leslie is, SCAD related to cardiomyopathy. I have FLNC variant, 2 cardiac arrests, but recently suffered from a SCAD heart attack. So tell us, Neil, I think hopefully that formed a good enough question for you.
Yeah, no, I mean, I think this is very unfortunate. It's bad enough to have cardiomyopathy and it's bad enough to have SCAD. It's unfortunate to have both. And the best of my knowledge, this is lightning striking twice. FLNC is, to my knowledge, not associated with spontaneous coronary artery dissection, which is SCAD. And I think the only question I would really sort of harp on is how sure are we of the SCAD diagnosis, to make sure that that's the cause of the heart damage that was seen. I bring this up because there is a growing appreciation that some patients with filament C related heart disease can have acute inflammation of the heart muscle, which can be associated with elevated blood markers of troponin, which is sometimes seen in heart attacks. And people who have SCAD also have elevated troponin because they're having a heart attack. So I don't know the connection, but I would just want to make sure that it was really a SCAD diagnosis.
Great, thank you. That's good. Appreciate it. From Jen, And Neil, I think again, I know you know quite a bit about DSP also. When do you think there will be a genetic therapy for DSP? And what about DSP makes it challenging to develop genetic therapies?
Yeah, so I think that there are definitely groups who are working on gene therapy for DSP heart disease. So I don't think that we are too far away from initial studies. It is simply a size problem. DSP, like Titin and like filament, are very big genes. And currently, gene therapy utilizes a virus, most commonly something called AAV9 or adeno-associated virus. Uses a virus as a capsule in which the gene we want to replace is inserted. That virus is not big enough to fit certain genes, which are too big. And so different types of gene therapy approaches will be necessary, but it's an area of active development. So I'm hopeful for DSP, for patients with DSP, that we'll have options in the coming years.
Great. Do you, not just a quick follow-up, a lot of the therapies that are coming to market will be AAV therapies, as you mentioned. And do you think, coming behind them are more of the sort of RNA therapies? Do you think for Titin DSP that they may better fit those potential genes, or am I just asking a bad question?
No, it's a great question, because I think, with AAV, there are known toxicities to AAV gene therapies. So AAV is used not just for cardiomyopathy gene therapy, but for lots of other conditions. And we've learned about how it can be hard on the liver, the blood clotting system, and then there are some rare associated risks. And so there is a very active search for different ways of delivering gene therapies and other ways of accomplishing the same thing. So the short answer to your question is yes. The long answer is there's lots of different ways that could play out.
Okay, thank you. Kathy from Ella, is DCM only confirmed with an EF less than 45%? If MRI indicates dilation but a normal EF, is it suggestive of heart failure rather than cardiomyopathy? Or what would the differential diagnosis be? Likelihood of left ventricular atrial dilation developing into DCM? A lot of questions there. Answer how you so choose, and I can repeat anything if you'd like.
Yeah, well, let me just say that heart failure, number one, is a symptom. It's a constellation of signs and symptoms that result from a cardiomyopathy. And so people can have a cardiomyopathy and not have any symptoms, especially if it's in the early stages of developing a cardiomyopathy. Their EF may actually be normal, but they may have some subtle abnormalities found on MRI. And one of those could be just ventricular dilatation, that the heart chamber, the left ventricular heart chamber, or multiple chambers could be enlarged. There could be evidence of some fibrosis, and they may have no symptoms whatsoever. And so if they have a reduced ejection fraction, that makes the diagnosis perhaps a little bit easier. And, especially if we combine that with a enlarged left ventricle or other enlarged chambers, and then you have a pretty confirmed diagnosis of some sort of dilated cardiomyopathy. And I think that's the big question is, if that were to be identified, even without any symptoms, it's still, the question is, what kind of cardiomyopathy is this? And so, yes, and the differential for cardiomyopathies is rather large. Not all cardiomyopathies are genetic in origin. People can have other kinds of diseases, including probably the most common disease in the Western world that can lead to an occult cardiomyopathy would be coronary artery disease, which is where there's blockages that develop in the arteries that feed the blood to the heart muscle. And even people may not have any symptoms of that. That may be their sign, is that the left ventricle is dilated and the function is reduced. And so all of it warrants more investigation. There are other types of diseases. I think Dr. Lakdawala is an expert on a disease called sarcoidosis. That can also, people can develop a dilated cardiomyopathy that's associated with that type of dilated cardiomyopathy. That has other signs and symptoms associated with it, but sometimes it may be just that's seen initially. So there's a whole host of different types of etiologies for the development of dilated cardiomyopathy. But yeah, you can see there can be signs on an MRI, even if someone does not have symptoms of heart failure.
Great. Thank you very much. And Kathy, again, another question for you from Denise. My son tragically passed away, misdiagnosed as anxiety. Denise, our condolences to you. You found out that he had DCM and IVH. He also had 2 mutations of unknown significance. Am I able to get free testing somewhere for his twin and 2 other siblings?
Yeah, that's a good question, and you probably can, because he would be considered the proband, and he has other, he has first-degree relatives that could be at risk. And so if he was given the diagnosis for cardiomyopathy, kind of falls into this gray zone of variants of unknown significance, then his first-degree relatives could possibly qualify for getting tested.
Great. Thank you. Neil, a question from Ram. Have they identified more genes in the last 6 years, the last time I did genetic testing for HCM? And can they screen for all other heart-related genes these days, or one has to do that individually? And then again, the third question of that, do insurance companies cover these costs? So maybe talk about it. More genes in the last 6 years. So yeah, go ahead.
I think what we've learned about hypertrophic cardiomyopathy genetics in the last 6 years has more to do with diseases that mimic hypertrophic cardiomyopathy or look a lot like it to a cardiologist or on an echocardiogram. And so this includes conditions that maybe a pediatric cardiologist would be familiar with, like Noonan syndrome, where often adult cardiologists don't see those diseases, or some of the other features of those diseases are missed or become less prominent. And so compared to maybe 6 years ago, not all genetic tests for hypertrophic cardiomyopathy would have included some of the genes associated with these mimics. These mimics are sometimes called genocopies or phenocopies of hypertrophic cardiomyopathy. Really, the vast majority of hypertrophic cardiomyopathy associated genes we learned about as far back as the 90s. The second part of this question was, is it possible to do an expanded panel, or is it done as a few individual genes? It's almost always preferred to do it as an expanded panel. And my experience with the times I've asked for repeat testing in patients is we've been able to get it done. I haven't had an insurance company say, well, you did it 6 years ago. I suppose that's a possibility, but I know there are other really great opportunities to pursue genetic testing that can allow us to get around insurance companies.
Great, thank you. And then, and again, it's interesting. We have a very large international question base here today. So Niall from Ireland says he has the laminate gene, and Niall, so do I. Have a laminate gene, and I had an ICD implanted last year. A few weeks after the installation, I received 12 shocks. I have read that there is a development research around decreasing the pain of ICD shock. Is that accurate? Thanks. And any information on that, Neil?
Yeah, 12 shocks is tough. So we sometimes call that electrical storm because it is overwhelming for everyone, but particularly for Niall. I think that, especially knowing what I do about Lehman cardiomyopathy, the first thing I would wonder about is whether his ICD is set to use anti-tachycardia pacing. So that's a way of stopping ventricular tachycardia, preventing cardiac arrest, but doing it by pacing the heart instead of delivering a shock. So my team did research on this and found that for almost 95% of therapies that patients with Lehman-related cardiomyopathy needed, the pacing system would work as a first step, and that does not hurt. That doesn't give patients the same, whack in the chest and really throttling experience of an ICD discharge. So I would ask Niall's cardiologist to review his ICD settings and determine whether the programming could be expanded to include ATP if that's not already part of the current programming.
Great. Thank you very much. Kathy, this is a question for you from Jennifer. My son had DCM from birth. He was tested in 2009 for genetic causes and was found to have a novel mutation. He passed away waiting for a heart. Again, our condolences, Jennifer. One of my daughters also has the same mutation, but as well. I wonder what monitoring is recommended. She's been monitored throughout her childhood and is now going to be 18 very soon. Is repeated testing recommended? And my son isn't here to compare unless he has remained in a study somewhere. Thanks so much. Kathy?
Yeah. Yes, she should be monitored. She's 18, so she probably needs to establish with an adult cardiologist, someone who preferably has some expertise or experience with genetic cardiomyopathies. That person should try to get their hands on the actual genetic report of her sibling so that they know what the, or her own genetic report from the past, so that they know what the variants are that she has, and once that information is obtained, and let me just say, if that information can't be obtained, like if the records are not readily available, or then she should be retested for sure. But yes, she should be established with a cardiologist, and she needs to be clinically followed. Because if she is genetically affected, it's really hard to know when or if she will develop symptoms or early signs of developing a cardiomyopathy, and that can be monitored for. And the earliest, that is identified, then the earliest we can, start providing appropriate therapies for her to try and keep her as healthy as possible for the rest of her life.
Great. Thanks so much, Kathy, for that. Next question, and this one's for Neil from Christy. Hey, Christy, how you doing? Why does Entresto and other heart failure meds seem to work better for some individuals with cardiomyopathy than others, even with the same cardiomyopathy gene variation and/or EF, ejection fraction? Are there factors that will predict how well medications may work? And I'm excited for that question because I think, Neil, you and I have had this discussion. So
yeah. I mean, this question transcends genetic cardiomyopathy. I think we see this with all medicines and all diseases, that there's a tremendous variability in most diseases as to how the standard medications work. And it's so much so that when we talk at medical conferences about how valuable a medicine is, we talk about something called a number needed to treat, which means we're going to need to treat this many people with this condition to actually see a benefit in one of them. And that sort of implicitly acknowledges that not everyone is going to get the same benefit out of the same medications. And that's not to detract the value of those medicines. It's just that there are factors that underlie that variability that have been appreciated for years. But what those factors are, I'm not sure that I always know, other than, in general, people who have a non-ischemic cause of heart failure tend to respond better to medicines. People who have not developed extremely severe dilation. So that can sometimes be measured on an echocardiogram with a diameter greater than 70 millimeters. Those patients tend to not respond as well. So if you don't have severe dilation, you may respond a little bit better or a lot better. And then for certain treatments, we can actually get very specific, like a biventricular pacemaker. We know that there are certain ECG characteristics that predict who's going to respond the best. But, Christy, that's a really important question. And I don't have a good answer right now as to why you take, in a sense, medical twins, why does one respond and the other not? It's obviously an area of active investigation. Great question.
Great. Thank you. Thank you very much. Kathy, I'm going to let you take a shot at this. Can you speak about HRT, estrogen, progesterone, and testosterone, and implication for those with cardiomyopathy? And then secondly, are there specific recommendations for exercise that are safe with individuals with dilated cardiomyopathy? And that's from Danette.
Yeah, Danette. I really can't speak to, and Neil may be able to add to this, any deleterious effects of, nor beneficial effects of estrogen and testosterone in cardiomyopathies. And that's all that I'm aware of. And so I know we get a question about this quite often, but and that's the best answer that I can come up with. And as far as exercise, I mean, I think that in cardiomyopathies in general, I think the general advice is, you should exercise to what you can tolerate. And there may be some variants, genetic variants, where exercise may be harmful or potentially harmful. And that's controversial as far as what the recommendation should be. That's my understanding. So it's not black and white across the board. But as far as general exercise, probably some degree of exercise is important. But, you have to learn each individual who has a cardiomyopathy, depending upon the type, the severity, a bunch of different factors, the medications that they're on, they will have a certain level of exercise tolerance. And some people, that tolerance may not be that great. I have seen other people that have what we would consider pretty, advanced disease, and they can exercise to a pretty good degree. So it's quite variable, and that's a very good question also to review with your cardiologist, who should be helpful in providing some more specific guidance to you as an individual.
Great. Thank you. Neil, anything on HRT, estrogen, progesterone, and testosterone for?
I mean, the main things I would add to Kathy's wise counsel is that oral estrogen likely increases blood clotting risk, and the risk of blood clots with transdermal or a patch delivery of estrogen may be a little less. And so what I would recommend is that the impact on blood clotting, which can be quite important for some people with cardiomyopathy, be considered in the context of HRT. So, if a patient is not on blood thinners and they have atrial fibrillation, that could be a higher risk or alternative. If you're already on a blood thinner, then maybe it's inconsequential. But that's the only thing I would add to that.
Cool. Great. Thank you. And Neil, this one is for you. From Jean, I was diagnosed with mitochondrial myopathy with a muscle biopsy at Mayo Clinic. Years later, after having a genetic test for my son who has cardiomyopathy, that test came back positive for Titin. In your expert opinion, is it possible to have both?
So I guess I'd want to know, knowing what we know now, do her doctors still feel like she has mitochondrial myopathy? Has it involved her heart? We certainly could, and I imagine that she has had testing to see if she also has the Titin gene variant that was identified in her son. It's possible to have both. They're unrelated conditions. Titin should not be associated with the classic features of a mitochondrial myopathy. But I do know that diagnosis of mitochondrial disease can be tricky. And one of the first questions she should ask her team is, are we really sure that this is what I had all along?
Okay, no, that is great. Thank you. And next question is from Char for Kathy. And I want to answer the first part of this, but does having a pacemaker increase risk? And is 70 years old too old to start jogging? Char, if your knees can handle it 70, I say go, but Kathy's got the expert opinion because my knees can't handle it 61. So Kathy, what is your answer there?
Yeah, well, just having a pacemaker in itself, you know, if your heart is otherwise normal, doesn't really increase your risk except for any complications or risks that are associated with having a foreign device in your body. And so, you know, outside of that, just having a pacemaker, no. You know, and if you have a pacemaker and you know, depending upon, again, there are many different reasons why people have pacemakers. And so I'm going to make the assumption, and the assumption may be wrong, but I'm making the assumption that, you know, this person may have gotten a pacemaker because they had a problem in their heart electrical system and they weren't getting enough heart, generating enough heartbeats, basically. And so, and if that was the case for getting or a reason why they have a pacemaker, then they're probably pretty safe in exercising at this point. They were much safer now than they were prior to receiving a pacemaker. So I would say if you're otherwise feeling well and it's okay with your cardiologist and medical team, then I'd say go for it. Having a pacemaker should not be a reason alone for not exercising.
Great. Thanks so much. Neil, here's a question from Dorothy. A little broad, but I'd love to get your thoughts. What is the prognosis for arrhythmogenic cardiomyopathy? I know that's a tough one and kind of a broad brushstroke.
Yeah, I mean, I would break it down into the individual cause. I mean, the prognosis is really different if we're talking about PKP2 related ARVC versus Lehman related arrhythmogenic cardiomyopathy, DSP, filament C, phospholamban. And so when I think about answering that question, I really want to get into the silo of the individual genetic cause. And then once you get to the individual genetic cause, probably the two most important considerations, or three for prognosis, are what's my risk of cardiac arrest? And it turns out for almost all of those diseases, we now have pretty good ways of calculating risk that help people like me give advice to patients about whether or not a defibrillator is helpful. And those will do things like generate a 5-year risk that you're going to run into a life-threatening arrhythmia. The second would be the risk of heart failure. And our ability to see into that crystal ball is probably in the 5 to 10 year time frame, and we use things like the ejection fraction in particular to help answer that question. And then stroke is another really important one, and almost entirely linked to atrial fibrillation, and can be prevented with blood thinners. And so particularly I think about patients with Lehman heart disease, their stroke risk is very high, but if you use blood thinners judiciously, they don't have strokes. So it's a specific answer, I guess. If Dorothy, you know, I think the next round she can tell us which gene she had in mind.
Great. Thank you very much. And I'm going to put the next question, and I'm going to have two parts to this and have Kathy answer the first and Neil the second. So a woman's diagnosed, found out she has genetic cardiomyopathy, 29 years old. What would you recommend she does for future pregnancy? I'm going to put this in two categories. One would be for potential PPCM. Kathy, if you could maybe talk about that, and potential risk of getting PPCM with the pregnancy. And then Neil, on the back end, if you could talk about the sort of potential IVF options for the baby. So Kathy, do you mind taking the PPCM piece of that?
Well, yeah, that's PPCM, or their pregnancy-related cardiomyopathy, is, we're learning more and more about this. For many years, it was really not thought to be, or it was greatly appreciated. Let me just say that there was really a genetic component to many of these cases. I think now we understand that there is a genetic cause for many women who develop PPCM, but it may not be the only cause, but we know that that's for a large number of women that end up with pregnancy-related cardiomyopathy, they do have a underlying genetic variant. And most commonly, to my knowledge, the gene that's involved is Titin. There can be other genes, I believe, that can be involved, but that's, to my knowledge, the most common variant, gene variant related to peripartum cardiomyopathy. And so, if you have a family history, I think family history is very important in dealing with people that have had pregnancy-related cardiomyopathy, because if there are other members, other women in the family who have also developed heart failure, specifically, that's how they become identified, is they develop heart failure towards the end of their pregnancy or very shortly after delivering, then then there's a very strong indication that they likely have a genetic form of peripartum cardiomyopathy. So, so what to do with future pregnancies is a challenging question, a very important question. And it depends. I think a lot of cardiologists would say that, if your ejection fraction remains reduced after suffering or being given a diagnosis of peripartum cardiomyopathy, that they would recommend that you avoid future pregnancies. It's a little bit more controversial in women who have normalized their ejection fraction. However, I would say one of the caveats of that is if they've normalized their ejection fraction, they likely have been on appropriate medical therapy. And some of that medical therapy would have to be withdrawn in a future pregnancy. So that, again, we know that those women are at increased risk of developing, again, heart failure with subsequent pregnancies. So it's a very important question, one that should be very thoroughly discussed with a high-risk OB and your cardiologist. And many times they will work together to try to help discuss the pros and cons of pregnancy with someone who might be interested in future pregnancies.
Great, thank you. What about IVF? Someone is a female or the parents potentially have genetic cardiomyopathy. Neil, what do you sort of know about the sort of potentially?
So there is a technology called pre-implantation genetic testing that I make patients aware of. It allows parents to have biological children while really minimizing the risk of passing along the disease-causing gene variant. And it involves undergoing in vitro fertilization, which usually results in 6 to 8 fertilized embryo. And then genetic testing is done on the individual embryo. And those that do not carry the gene variant are transferred to the mother's uterus. So it could be applicable either to fathers or mothers who carry disease-causing gene variants. How you have a family, how you start a family is intensely personal. This is subject to a lot of state regulation, insurance availability, but I definitely want to make sure my patients are aware that this exists and is out there.
Okay, great, thank you. And we got a few more questions. We have a hard stop at 7 tonight. Some people have some commitments. We apologize. but we'll get the questions, unanswered questions to you in the next few days or next week. We'll make sure that Kathy and Neil answer any of the questions you have and we get them to you, but it may run into next week, giving schedules. Next question from Stefano, the FLNC truncated mutation. What does, I think, exercise or sport activity have to do with this progression, Neil?
That's a great question. I think it's an area of active research. The short answer is we don't really know. I think what you want to keep into mind is the short-term risk of arrhythmia and then the long-term risk of progression. And to be blunt, I'm not sure we really have a good sense on either. It's something that my team is researching and I know others are doing as well. So stay tuned, Stephanie.
Okay, great. Thank you. From Jan, my mother and her mother both died at age 43 from cardiomyopathy. I have had 2 heart transplants, the first due to it, cardiomyopathy. My children have both had genetic testing. One has 2 genes related to it, and the other has 2 plus 1 that they didn't know exactly what it does, but it's related to cardiomyopathy, probably a VUS. These tests were over 10 years ago. Should I have them retested? And should I be retested too in case they have discovered more genetic information? So a 10-year-old genetic test and probably someone with a heart transplant tested, longer than that. Neil, should they get retested?
Yeah, I think it depends. This is a great question to talk to a genetic counselor about. There are some bona fide, 10 years ago we knew about it, and 10 years later we're still sure. That's why that person and her relatives struggled with heart failure and needed transplants. So it's hard to give a blanket answer as to whether there would be a role for retesting. I would say that we usually do not retest when we find a cause. Now, in the case of her children, if they previously tested negative for what we think to be the cause of cardiomyopathy in the family, we generally do not recommend retesting unless there's any reason to be doubtful about the veracity of the original test. And usually these are highly reliable tests. And so to answer that question, you kind of need to know the genetic test results of the panel that was sent. And I think this would be a great reason to see a genetic counselor.
Great. Thank you. I'm going to go to a question from Richard. I have and Kathy, we'll give you this to you. I've had a 3-lead implanted cardio device, ICD, that is non-compatible with MRI technology. I realize that most ICDs are being manufactured today are MRI compatible. Today, when someone with an ICD is replaced due to low battery levels, and the replacement inserted, so could basically, when you're getting, if you have a non-compatible MRI due to the leads, non-compatible MRI ICD due to the leads, when they replace the battery, can they put a new lead in, Kathy? What are your thoughts on that?
Well, I think it's the whole device, the leads and the battery part of the device as well. But yeah, nowadays, they do make MRI compatible devices, leads, and the actual battery part today. So it's possible to change out the battery part. Sometimes it's harder. It can be very difficult to change out the leads, and that may actually cause more problems than worth it. And so but for sure, the battery part can be changed out to, probably an MRI compatible battery, but the leads is a different story. So kind of good and bad answer there.
Great, thanks. And one last question, and this is for Neil, and then we apologize. Nikki's gonna wrap up, but this is from Melissa, and she says, I had genetic testing done on a set of triplets. And my results came back with an unknown variant, a variant of unknown significance. Would I be eligible for clinical trials given the results? I was told that this result only known to me and not anyone else. So the question is, so someone gets a genetic test back, Neil, and has a VUS, would they potentially ever be possible for research or clinical trials?
Yeah. I mean, I guess I think about this as resolution of a variant of unknown significance. We want to get out of that indeterminate category and say, okay, it's either benign or it's a problem. And so we are learning more about the human genome. We are bringing to bear new tools that can help us understand if a particular variant is disease causing. And I'm going to sound a little bit like a broken record, but this would be another reason to revisit with a genetic counselor. They'd be able to really quickly review with you the resources available to help understand if our understanding of that variant has changed over time.
Great, thank you. And with that, the National Society of Genetic Counselors has a link where you can actually talk to genetic counselors. So the NSGC, National Society of Genetic Counselors, is great. Highly recommend genetic counselors for getting this type of information. So thank you. Again, we apologize for having not able to answer all the questions. We will get these to you most likely next week. Neil, thank you. Kathy, thank you very much. Justine behind the scenes. Nikki, thank you. And please take it away.
All
And
right.
thank you all for attending this evening.
Justine, if you can bring our slide deck back. Just find the slide with our sponsor logos, which should be next. So just want to thank all of our sponsors whose logos you see on the screen here. Their support allows us to present this very important information. And thank you again to all the patient partner groups for their ongoing support. As stated earlier, you will receive an email with a recording of tonight's webinar. And stay tuned for details on upcoming webinars. We will post registration information on the DCM Foundation and GCAC websites. And remember, if you can't attend live, just register and you'll receive a copy of the recording of future webinars via the email. As we wrap up tonight's Q&A, we want to sincerely thank our panel. Your insights, expertise, and dedication to improving the lives of those affected by cardiomyopathy mean so much to this community. We are deeply grateful for the clarity, compassion, and hope that you've shared with us this evening. And to all of you who joined and asked questions, thank you for being a part of this conversation. Together, we're building a stronger, more informed community of patients, families, and providers. Be well. We'll see you soon.